Hello, everyone. My name is Darlene Magdalinski, and I will be playing in role A for our condition presentation Delirium. I'm a little bit nervous, but I'm going to go ahead and do the best that I can. Role B will be my dyad partner, which is Shahida Williams. So I'm going to go ahead and get started. So I may look down a little bit, but just work with me, okay? Um, Delirium. We believe that delirium takes a community to come together. And part of this community is family and friends, hospice caregivers, nursing home caregivers, chaplains, and volunteers. Also, my delirium description is delirium is considered to be a neurocognitive disorder, which is a common acute neuropsychiatric syndrome. Normally, it will affect older clients who suffer with several medical issues. At least 50% of older adults in the hospital has had delirium at one point or another. Also, delirium could affect anyone, but it is less common in kids. Now, according to the American Psychiatric Association, delirium also can vary based on the person's characteristics, the setting of care, and sensitivity of the detection method. The prevalence is highest among hospitalized older adults as well. Also, according to the American Psychiatric Association, the delirium diagnostic criteria, DSM and DSM-5, um, the symptoms can be a disturbance in attention. The disturbance develops over a short period of time, normally in hours or a few days, and tends to fluctuate in severity during the course of a day. Also, they have additional disturbance in cognition. Disturbance in criteria A and C are not better explained by something pre-existing, established, or evolving in NCD, which is neurocognitive disorder, and do not occur in the context of a severely reduced level of arousal, such as coma. Also, there's evidence from the history, physical examination, lab findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal. Some associated features supporting delirium diagnosis would be disturbance in sleep and wake cycle, which, for an example, daytime sleepiness, nighttime agitation, difficulty falling asleep, excessive sleepiness, wakefulness through the night, emotional disturbances, for example, anxiety, fear, depression, euphoria, and apathy. Also, you find some of the associated features can be yelling, screaming, cursing, muttering, and even sometimes moaning. And this is according to the American Psychiatric Association as well. Also, the delirium differential diagnoses are psychotic disorders and bipolar and depressive disorders with psychotic features, acute stress disorder, malingering and factitious disorder, and other neurocognitive disorders. And for example, what I want to say when I talk about other neurocognitive disorders is what the DSM-5 is saying is do not confuse the symptoms of dementia, or rather determine if the patient has dementia or Alzheimer's disease by considering if they have a pre-existing condition. Because sometimes, again, dementia as well as Alzheimer's can be a little bit similar to like with delirium. So that's why they felt that was important for the social worker to understand and know that. Some types of delirium will be substance intoxication delirium, substance withdrawal delirium, medication-induced delirium, delirium due to another medical condition, and delirium due to multiple etiologies. What I made sure that I put here on the slide is if you do diagnose a client according to one of these particular types of delirium, please specify if it is acute or persistent. Some symptoms of delirium, and this symptom here that I'm going to describe delirium, I want to compare this, and it goes back to what I was just talking about with dementia. Now, some symptoms of delirium will start suddenly. Now, this is a condition that is similar to delirium, which, like I was saying before in the prior two slides, which is dementia. That slow mental decline over months to years. Now, delirium is temporary. It is resolved when cause is addressed, sometimes hours or days, and sometimes weeks or months. Whereas though with dementia, it's early on, you're alert, oriented, normal behavior, and you don't have hallucinations. Now, there are some symptoms of delirium, but some subtypes. And these subtypes are hyperactive delirium. So that means, like with hyperactive delirium, you can pose symptoms of being aggressive, incoherent speech, disorganized thoughts, delusions, disorientation, and hallucinations, refusal to cooperate, and mood agitation. Hypoactive delirium is sluggish, drowsy, less reactive, sullen, looks withdrawn, and you get like a stupor. And then you have mixed delirium. And this happens suddenly, and it's on and off over hours and days. And with this as well is um, when you're diagnosing with delirium, please specify what the subtype is. So is it hyperactive delirium? Is it hypoactive delirium? Or is it mixed delirium? And what I felt was important is to include the clinical features. So it kind of sort of helps you with the clinical features, because with the clinical features, it talks about, okay, the percentage of how many patients or clients rather is hyperactive. So with hyperactive, there's 25% that are hyperactive. There's 50% that are hypoactive, and then there's another 25% that are mixed. And again, with hyperactive, according to the clinical features, it's restlessness, heightened startle, hypervigilance, increased alertness. With hypoactive, you're lethargic and mute, initially perceived as oppressed or dementia state. So I think this is a great guide, for us as social workers. And then it talks about how the hyperactive, hypoactive, and mixed is more of like an arousal. Now, from a clinical perspective, the perception is inability to discriminate sensory stimuli and to integrate current perceptions with past experiences, obsessed with irrelevant stimuli and misinterpret objects in the environment, and auditory and visual hallucination. Now, as far as language and cognition, that would relate to like nonsensical rambling and incoherent speech, or sometimes completely mute, and impairment of primary and secondary memory, and remote memory may be preserved. Some causes and risk factors of delirium. Unfortunately, the cause is not quite understood. However, like some other conditions, there are no single cause either. So the risk factors that are associated with delirium could be recent surgery from a narcotics medication such as benzodiazepines, hypnotics, etc., or underlying disease such as dementia, constipation, pneumonia, etc. Chronic fatigue from not sleeping well in the hospital. This can make the symptoms worse, by the way. Also, delirium can also be increased in the context of functional impairment. And also, finally, immobility. There's a history of falls, low levels of activity, and use of drugs and medications. And all this is according to the American Psychiatric Association as well. They have three theories according to delirium, and one of them are largely the level of neurotransmitters. For example, it's going to be kind of hard for me to pronounce this: acetylcholine, dopamine, or norepinephrine, and glutamate. The second theory is there's issues with neuronal membrane that does not depolarize correctly. And the third theory is inflammatory. So these are the three theories of what they're just assuming what causes delirium. They're not sure, but these are just the theories, like I said. Some preventions for delirium from a medical perspective. It is said that if physicians notice a history of delirium in patients' medical report, nurses notice patients not sleeping well, and pharmacists notice patients on medication for opiate control, this could be a great preventative measure for older adults. Some examples are below that may help some patients that I'm going to talk to you about. So some things that what the medical field could do is help patients feel like they're in their home environment. Reduce the noise. Turn off the television to help them to feel more calm. Make sure that if they are wearing spectacles, and what I mean by that is glasses, that they're are on if they have any. Hearing aids are working if applicable. They're eating healthy meals and they stay hydrated. Also, I found a very, very, very informative video, according, that's really good related to delirium. And you will find our video that's related to delirium here in this link below. So thank you for watching my video, and I'm going to go ahead and turn it over to Shahida.